This is Going Under, Anesthesia Answer with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We are brought to you, as always, by our good friends at Butterfly Network.
All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs right into my compatible smartphone or tablet, so I can start scanning at the bedside in minutes. If you've used the older versions, or even if you're new to the handheld ultrasound game, let me tell you why this new IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster, whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short and long axis simultaneously, which is huge for procedural guidance and honestly a great tool for learners. The new needle out of plane preset even shifts the scan plane digitally so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality, honestly, the IQ3 holds up against some of the cart-based systems I've used. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com.
Well, we just got a host of new listeners over the course of the last 2 weeks, so welcome in to Anesthesia Answered Going Under.
Great.
With Dr. Brian Schmutzler. And this week on the podcast, we're talking about the incredible, not edible in this circumstance.
Well, I guess you could eat it, but
incredible edible egg. So egg in anesthesia is a big topic.
Yes, and so it's kind of a play on the time of year. So we're filming this on Easter Day. You can see I'm in my coat, my sport jacket here. So coming straight from church, and so obviously Easter is about the resurrection of Jesus. I thought about doing the podcast on like the Lazarus effect, which you may have heard of before, but that was going to be a little bit too intense. So I thought I'd lighten it up a bit. So Easter is also about the Easter Bunny, and the Easter Bunny brings eggs. So let's talk about how do eggs interact with anesthesia or play into anesthesia. So did you know that the most commonly used anesthetic agent, which is called propofol, is made with egg?
I did not know that.
Did not know. Well, no. You do now.
Well, I do now.
Yeah.
I'm smarter now that I've listened to this podcast.
So it's a drug we use every single day.
Yep.
Help patients on induction, so help them get to sleep. It contains egg lecithin. So the lecithin is kind of a different portion of the egg. That it's not just the white, just the yolk, but we'll talk about that in a minute. And so like I said, today, since it's Easter, let's talk about eggs.
So, okay, how is it made in the drug, I guess? Like, why do they put that in there? Give us a background of why that ingredient was put in.
So propofol is very what we call lipophilic. So it likes to be in fats. And you can't just take a substance that likes to be in fat and inject it in the body. Otherwise, it's not going to get where you want it to go. So the lecithin is lipophilic on one side and then hydrophilic on the other, meaning that basically it can glom onto those propofol molecules, but then also travel through the blood. And when it gets broken down, the propofol gets released where it needs to go. So it's formulated as a lipid emulsion, meaning it needs fat to be delivered safely into the body. And so the egg lecithin is actually, even though propofol is white, if anybody's ever seen it before, it's bright white. It's actually derived from the egg yolk itself. So people who come in and say that they're allergic to egg whites and think they can't have propofol, it's actually not true. The lecithin comes from the egg yolks, but we'll talk more about that later anyway, that, the egg allergy thing's kind of a misnomer.
Okay. So, the pharmacology of it, the chemistry of it, how does that come together with this?
Yeah, so propofol, we'll just describe the drug a little bit, basically. So propofol is the most common induction agent. I can't remember when it came on the scene, probably the late 80s, early 90s.
Yeah.
And basically what happens, it's a very fast-acting drug that goes away very quickly as well. Pretty safe. It's got a pretty good lethality window, right? So you can give a lot of it without it actually causing a huge issue. And so we use it on almost all inductions. And it's pretty smooth. It's actually antiemetic as well. So it means it prevents you from vomiting, which is why we use it so often in our sedations for things like colonoscopies, endoscopies, even for when we do a spinal for, let's say, a total joint. So,
but propofol has been in the news recently.
Not recent.
Well,
years ago. Yeah.
Years ago. I mean, but not only with Michael Jackson, Prince, but also
Prince was fentanyl,
but also who's the Matthew
from
Friends.
Yeah. Matthew Perry. His was ketamine and opioids.
So for propofol though, are they like? Is that something that you can get prescribed like a normal person?
No, it's not. It should not be a drug of abuse. It's only IV. That's the only way you can take it.
How are these people getting a hold of it then?
Well, allegedly, Michael Jackson got it from his physician, who was a cardiologist who just took it from a hospital. And so what happened, and this is a very convoluted story, but basically what happened is after Conrad Murray took the propofol and gave it to Michael Jackson, he walked away and wasn't monitoring him. So propofol is incredibly safe if you're monitoring, but it does slow down your breathing. It does slow down your heart rate. So you have to watch the patients. So after that, though, the laws changed where you actually have to have a certified anesthesia provider to give propofol now. So it used to be nurses could do sedation with propofol, and because of how wildly popular Michael Jackson was and how the story broke so widely, now you have to have an anesthesia provider to do propofol.
Okay, so anytime you use propofol,
you're supposed to have an anesthesia provider there. Yeah, and there's some exceptions to that, like low doses in the ICU. You don't have to have an anesthesiologist. It's typically ICU doc. They use it sometimes for sedation in the ER, but like procedural sedation in general, it has to be done by an anesthesia provider.
So take me through the process then. And this is the part where I don't think a lot of people understand or know, is that when you're back there and you're monitoring the anesthesia, there's dosages, right? I mean, you're like constantly adjusting levels of this.
Yeah, so propofol is what we call an induction agent. So we just give a slug of it, a lot of it on the front end to get a patient fully to sleep. Now, if we're doing a sedation, we do titrate it. So we'll give 100 mics per kilo per minute or 200 mics per kilo per minute or 50 mics per kilo per minute to keep a patient asleep at the level we want them to be asleep. But yeah, and it's not, as patients get older and larger, we're not quite as precise on the exact dose, right? So a lot of times we give what's called a unit dose. So propofol comes either in a 20 cc vial, so 20 milliliter vial, 50 milliliter vial, 100 milliliter vial. So a lot of times to go to sleep for most patients who are relatively healthy, you just give the whole 20 milliliters. It's got such a wide safety range that the difference between 12 milliliters and 20 probably doesn't matter. So a lot of times we just give full doses of it.
So let's go back to the question about being allergic to dairy.
Yeah.
If you're allergic,
not dairy, eggs. Yeah.
Is it safe to use propofol?
Yes. Yeah. So the cross reactivity of people who claim to be allergic to eggs and propofol is almost zero. Now, we can be a little bit overly cautious with it. If somebody says that, every time I eat an egg yolk, my throat swells up, I have to go to the hospital, I have to get a shot, then usually there's some other drugs we can use. Ketamine's a good choice. Dexmedetomidine or Precedex is a good choice. Etomidate is a good choice. There's a lot of other things that we could do, but nothing has quite the rapid onset, predictability, and quick recovery as propofol. So that's why it's so great for, let's say, a colonoscopy, because quick on, the GI doc can go and do their thing real quick, be done, and as soon as they're done, you turn it off and it goes away really quickly. Some of these other drugs, they linger. Yeah, there's much more lingering to it. But yeah. So there are some side effects. It's pretty rare if you dose it well, but low blood pressure or hypotension is a pretty common side effect. Now, in you or I, if our blood pressure drops 20 points, it's not going to hurt us. If somebody who has massive heart failure and is already 100/60 and drops 20 points, it's a problem. Again, so we monitor these patients. Typically, depending on the dose, a low dose of it won't cause respiratory depression, won't make you stop breathing. It will cause depression, but it won't stop you breathing. A high dose of it, though, almost in everybody stops the breathing. Now, if we control the breathing on our own, like in the operating room, then it's fine. But if you inject propofol into somebody who, let's say, isn't monitored and is laying in a bed in a house in California, and then just walk away and go drink a beer, you're going to have a problem. So...
So many questions.
Keep asking.
Well, why, obviously there was, if it's dangerous, why are you just letting the patient handle it?
Because he's gotten away with it before, I'm sure. Conrad Murray would do this. It sounds like, anyway, again, allegedly, I don't know the whole story, right? I don't know the transcripts, but allegedly he had done this for a long time. Just give Michael Jackson the propofol, inject it, walk away. So eventually, though, either gave too much or he was also mixing with alcohol, whatever the case may be.
Yeah.
Ended up dying from it. So
We had a question. That
Oh, wow.
to bring
Okay.
up.
All right.
But I'm trying to find it now. So that's. Sorry for the.
No, it's okay. I keep riffing on propofol a little bit. So, as I said, giving an exact dose is not always, perfect, right? We have dose ranges, but if you give everybody the same dose, some people are going to get overly sleepy. Some people aren't going to get sleepy enough. And so we're constantly adjusting, not only like kind of in a bolus or when we're giving a patient propofol to go to sleep, but we're adjusting if we're giving them an infusion as well. Always looking at things like blood pressure, ventilation, the depth of anesthesia. Are they moving around? How stimulating is the surgery? Like a total knee when they're totally numb from a spinal block is not actually as stimulating to a patient as, let's say, an endoscopy where you're putting a scope down somebody's throat. So.
Awesome.
Did you get the question?
I did, but it has nothing to do with this.
That's all right. We can answer it if it's.
Are we done with our anesthesia and egg conversation?
Let me see if there was anything else we wanted to talk about in terms of eggs.
Other than you can color them and put them in an Easter basket.
Yes.
Which you can also, not real ones.
Yeah.
I mean, real ones you can, yeah, but.
I think that's kind of all we have about the eggs. I just thought it was kind of interesting. I'm thinking about what do we talk about in terms of anesthesia for Easter, and like I said, maybe next Easter we'll do the Lazarus effect, but
which is interesting.
Yeah, it is interesting. But I think the egg thing was a kind of a soft one. Yeah.
Well, if you have any questions too, I mean, this is really what we love about the podcast is that it opens it up to some questions that Dr. Schmutzler receives online. And one of the questions that somebody sent in from Michelle Bryan says that I am a I'm a CRPS2 patient.
Okay, yeah. Condition, regional pain syndrome, chronic regional pain syndrome.
Due to a crushing injury to my sciatic nerve in 2012. She said, my entire right leg is involved from hip to toe. I've had 2 sympathetic nerve blocks.
Yep. Yeah, it's a pretty common thing that they do, yeah.
1 radio ablation.
Radio frequency ablation, yep.
And a failed spinal cord stimulator.
Okay.
She said, what can I do now? I am unwilling to do another spinal cord stimulator as the first one nearly killed me. So please don't suggest another one. And this is coming in from Michelle. Michelle, thanks for the question.
Yeah, so CRPS is tough, especially when it comes from an injury and not something that, the insidious onset CRPS is sometimes easier to treat than something that comes from a crush injury. So, I mean, the process is, and I'm not a chronic pain physician, so I don't know this as well as some chronic pain physicians will, but the process is the first thing you do is medications. So sometimes medications like gabapentin, for instance, even opioids sometimes will help. Sounds like she probably went down that path already. You do that in conjunction with physical therapy. Again, she probably went down that path already. Radiofrequency ablations are trying to kind of burn the nerve. Sometimes that helps. The sympathetic blocks actually are usually pretty effective. And so I don't know how many she had, but I think people typically do a series of 3 or 4 of them. So that's another possibility. Sounds like the spinal cord stimulator didn't work that well. There are some new kind of experimental things that are coming out, but that's way outside of the purview of what I do. I would say just stay in contact with a really good chronic pain doc. And then I think some of the alternative therapies, acupuncture and massage and all that sort of stuff, is there great data they help? No, but they probably do a little bit. So, continuing physical therapy and then chiropractic, acupuncture, massage, that sort of stuff.
It's great that people, when they send questions in, because they're genuinely just interested in how you can, do you have the knowledge? Can you answer the question and help them?
Sometimes I can answer part of it. Sometimes I can answer all of it. Sometimes I can't answer any of it.
So pain management.
Yeah.
Well, while we're on the topic, let's just talk a little bit about pain management.
Yeah.
Dr. Brian Schmutzler.
Sure.
And maybe some of the...
Acute or chronic.
Yeah. Maybe both. And some of the misconceptions out there.
Yeah. So I mean, I think chronic pain, acute pain wise in the operating room, which is what I do. I don't do chronic pain. And I know apparently this is a big buzzword for people who don't like it nowadays, but multimodal analgesia, which means using every possible technique to treat the pain, including opioids when needed. But other things like anti-inflammatories, things like, as we talked about, Tylenol. IV Tylenol is incredibly effective. Even more so than oral Tylenol. Things like regional anesthesia, where we numb up nerves, I think is a very good thing. There's some other, nerve type medications that we use. And then again, similar things like acupuncture and, physical therapy and all those sort of things. They all work together to treat acute pain. So when you say multimodal analgesia, you don't mean no opioids. You mean using multi-modes to treat pain. Anyway. Chronic pain, I can't speak a whole lot to. I mean, I know kind of the process is, you initially treat with an anti-inflammatory. I mean, I just had a back issue recently so they treated me with an anti-inflammatory. If that doesn't work, then kind of the next step is physical therapy, do some imaging, figure out what's going on. If it's something fairly amenable to injections, then sometimes you get the pain injections from a chronic pain doc. And if that doesn't work, next step might be surgery or minimally invasive surgery, or, there's all kinds of things you can do for chronic pain. So in general, it's not great for people to be on long-term opioids. And, I've got a little bit of cachet in this because this is what I studied in the lab. But if you take opioids long-term, they are, number one, you create a tolerance to them. So you got to take more and more and more of them to get the same pain-relieving effect. Now, that tolerance does not mean addiction, but tolerance does mean higher and higher doses. And the side effects of opioids, which are really not good things, right? Like respiratory depression, so you slow down your breathing, constipation, there's some changes in your hormonal levels. So there's a lot of things that go on when you take opioids chronically. Now, you take them for a few days after surgery, the likelihood of those things happening, pretty small. You take them long term, 6 months, a year, 10 years, those side effects are much more likely to occur. Again, because of escalating doses. There is an addiction potential to opioids, which there is not to a lot of these other medications like steroids, like numbing medications that we use in the operating room. You're not going to get addicted to that. So, there's that potential as well long term.
All right. Well, if you have a question for Dr. Brian Schmutzler, as always, send him a message, add him at Twitter, Facebook, Instagram, whatever it is. If it's a question related to medicine, you will answer it.
I will do my best. Yeah.
Absolutely.
There's certain areas of medicine I don't know as well as others, but if we want to talk about, the operating room, anesthesia, some pain management, acute and subacute pain stuff, happy to answer the question.
We are brought to you by the Butterfly Network. This has been Going Under Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Saderzadeh.
See you next time.